at your level.
And also, ma'am, I just want to ask one or two questions about examination.
Yes.
One thing is, in general, that for the Perthes examination, can anybody tell me how we do this examination, Perthes?
Okay, I'll tell you. But
For
first, Dr. Mavish history taking. Dr. Mavish, when patient told you about having a kidney problem, and then you said, okay, fine. Most of the time, at the end, okay, you said, all right, I'm sorry to hear this. But most of the time, when you hear these sort of things, then you should say, I'm really sorry to hear this, or these sort of sentences.
Yeah.
Yeah, okay.
Yeah. Anyone else want to give feedback to Dr. Mavish? And then we'll answer Dr. Astra.
I think Dr. Mavish covered all the points of the.
She asked everything. It's just
thing.
that she hasn't practiced, so
she asked
took
everything.
2 minutes extra. She took.
She took a bit of the hints and the help, but the rest, everything she asked.
Yes, she covered
like
everything.
in a chronological
Yes.
sequence, which is good.
She asked even the
because in the
family
mid I
history.
got confused that am I mixing it with the Caesars now, because I have got this problem now of mixing stations.
No. But here you were focused.
When you asked,
No, you were
when
focused.
she started asking me, what were you doing? Were you feeling? Then, okay, I was like, is she going to that? But no, good. You got on track.
She was on track, yes.
Yes. She pulled on track, yes.
Okay, anyone can answer Dr. Astra's question. Thank you, Dr. Mavish. Thank you.
Thank you.
Yes. Dr. Abhishek, please.
First of all, ma'am, I'd like to say for Perthes, with Perthes test, what do we check? Actually, any deep venous insufficiency or not?
Yes.
Deep venous incompetence or not? So there are two Perthes tests actually: modified Perthes test and one is Perthes test. For Perthes test, you have to keep the patient lying on the couch and ask about if do you have any pain in the hip joint, because I'm going to lift your leg without bending. And after that, you will just lift the leg with bending, and you will wrap it with a tourniquet, something like that. Wrap it from the ankle, from the foot towards up to upper 2/3 of the thigh. And after that, you will just ask the patient with that wrapping to work a few distance. And if the patient complains about severe pain for this, the vein cannot, the vein is pulled back to the superficial system, so patient is having severe pain for the incompetence, that is called Perthes test is positive. And rather going to direct towards the femoral vein to the heart, patient is going from the deep venous system to the superficial venous system. So this is called actually the Perthes test. And the modified Perthes test, by it we mean actually you will lift patient's leg in the same way. You will just milk the veins actually towards the saphenofemoral junction, and after milking the whole vein, you will just occlude it with your hand at the saphenofemoral junction and ask the patient to stand up. Or you can do it with the tourniquet actually. You can do it with the tourniquet, and you just tourniquet it at the level of saphenofemoral junction, then ask the patient to stand in his jog or walking in his place without changing the place. So if the venous vein again appears, and patient is having severe pain, it will indicate also the deep venous insufficiency. And for the varicose vein examination, we actually do the modified Perthes test 1, because the making of multiple small perforators, multiple incompetent perforators is not always possible if there is a vein. So we actually do the modified one. In case of primary varicose vein, the modified Perthes test will be negative, and in case of secondary vein, the modified Perthes test will be positive.
Good.
Am I clear?
Yes.
Okay. Yes. Thank you.
Astra. Is it clear?
Yes. Good. And also, ma'am, I have one more what I wanted to ask. Yes. So I was actually reading. We were reading the station past papers about regurgitation. It was about a station about mitral regurgitation murmur, it seemed like. But is it possible that we can get a station which patient has mitral regurgitation also has valve placement, both of them?
There
Yes,
may be.
okay.
Yes.
Yes,
Okay.
possible.
And what could be the
Okay.
echo finding? We were doing the echo finding as well. I couldn't get the echo
Yes,
finding of the
yes,
mitral
yes.
regurgitation. Can anyone tell what is the echo
Yeah,
finding
you
for
will
MRCS?
find a regurgitation jet, definitely more than 1 to 2 centimeter, first of all. Then in case of mitral regurgitation, you will find the regurgitation jet, and also the echo findings you have found actually that in the endocarditis, the rheumatic heart disease section in the SING notes, you can find it there. Like you can find there is something like ventricular dilatation or something like annular dilatation, pericardial, subendocardial ischemia, regurgitation. The regurgitation that is mainly important in this case, I guess.
Yeah.
Okay.
Okay.
Dr. Sunday, what do you say actually?
Dr.
I don't
Sunday,
know
you
much
should
knowledge.
talk as well because
Yeah,
your
plus
exam
or,
is so
Yeah,
close.
of course.
Yes, please
yeah,
talk.
plus or minus to the valve in
Yeah.
And
Okay. Focus
what
on
does it
valvular
actually mean? Like, for example, if a
regurgitation.
patient has mitral regurgitation and also have valve replacement, it means that valve replacement has failed, isn't it? Because the patient is now again having regurgitation. Like, patient must have had valve replacement due to some reason. And now
Yes,
again, if patient is having regurg after the valve, it means
yes,
there is incompetency of the valve, isn't it?
yes, yes.
Okay.
Or maybe it may be a different valve.
Uh,
Maybe a
yeah,
different valve.
don't be confused. The valve on the
or failure technique. Yes,
for the heart, we have one for aortic, the mitral, the tricuspid, and the pulmonary. So it's possible that they did a aortic valve replacement for the patient before, and now just having a mitral regurgitation. It's possible.
that is
So and it's
also
possible that
possible.
the aortic
Yes,
has failed. So, but that you can tell during examination by listening to each heart sound. So
yes,
if you see murmur at the apex, and then you hear metallic click at the second intercostal page right to the sternal edge, then you know the patient has aortic valve replacement plus mitral regurgitation.
Okay. And what are the
So
pre-operative or invasive precautions for such a patient we can take who has mitral regurgitation?
yeah, of course. Like Dr. Fisher said, during echo, depending on the size of the regurgitation, if it's more than 2, then probably we might need to consult the experts for them for us to be sure that we can continue the operation. But if it's less, then we can proceed with the operation. Then we have to be mindful of the history of the previous valve replacement, so which means anticoagulation. So we have to follow local policy and make sure we change the warfarin to heparin about 7 days with the operation. You know the procedure, the protocol. Then follow the protocol, yeah,
Yes,
which
yes,
we have to
yes.
mention because that's very important.
Which one?
You know,
Sorry.
anticoagulation management.
Okay.
So,
Coagulation,
also
warfarin for
antibiotics
warfarin.
according to NIST guideline, which if is an depending on the operation they said in this, the operation they said the special operation, probably no need for antibiotics. But if it's a deep operation, then there will be need for prophylactic antibiotics. So we have to be mindful of all those small tiny details.
Okay. And can you tell me one more thing that, like, you know, in this a patient, like, who are the patients who are put on the warfarin? They are generally those who have had who have pacemakers in, or who have atrial fibrillation. But any patient who has undiagnosed regurgitation, he won't the blood thinner. He won't be.
Because if it is undiagnosed, then it won't be on blood thinner.
Yeah, he won't be on it.
Yeah, yes,
Okay.
definitely.
And can you tell me what is the
Okay.
intraoperative precautions for this? Because anesthesia would be affected, how this patient would respond?
The thing is, if we know that the patient is not so fit, so we might need to inform the anesthesia to be careful because that means the patient, according to ASA grouping, might be having maybe 3 or 4. So which means you need to tell the anesthesia to be careful. But the most important thing is INR monitoring and the prevention of the bleeding, because the patient is prone to bleeding. So, and also preventing infectious endocarditis, which is a possible complication also for this kind of patient. So,
Yeah.
and also
I think,
maintaining.
I think maybe it would be like, because this seems like a totally new thing. It may be like somebody has missed a part of the question. It might be that patient had mitral valve regurgitation and then had valve replacement,
Yeah.
and maybe they were
What,
then asking about the preoperative and intraoperative concerns. So then we can say all about the blood
exactly.
thinners and all this thing. Otherwise, it doesn't make sense that if patient has mitral regurgitation, what preoperative or intraoperative precautions we can take. In that case, we should rather go to the cardiologist and see that,
Exactly.
what, or have the echo done and see whether the patient is fit for surgery or not first. The
Perfect.
patient can't go for surgery if patient has newly diagnosed mitral regurg.
Perfect. That is what
Yeah.
question.
If
So
it is
just
a
follow.
Yeah.
elective
I think
surgery, the
maybe
patient should
somebody
not
missed
go.
a part of the question.
Can I say something,
Yes.
if you don't
Yes.
mind? Yeah, like Dr. Sande have told everything like that. So if intraoperatively, Dr. Sande told continuous monitoring from the anesthetist. But for me, I would like to say that you remember, like whenever we can transferring a patient to another hospital, the ambulance, like in a communication skill with cardio version equipment, proper cardiac monitoring, and also the CPR instruments available. I would like to focus on that first. These things are available in the OT all the time, and if possible, a cardiologist may be present. From my point of
Okay.
view,
Of course.
intraoperatively, a precaution for
Of
this
course.
patient.
With what do you
Yeah.
call it? With what do you call this machine for shock, adversion, and this thing, defibrillator machine
Yeah.
available, because you are dealing with the heart and anything could go wrong. So just a general precaution. You don't need to think too deep. General precaution according to zero.
No, we were just confused because we were thinking that new sessions are coming like one after the another, because we have basically done that 2 or 3 conditions. One in which patient has aortic stenosis, in which case patient if is fit for go to surgery or not. So obviously we will say that we will do the echo. We will see what the level of stenosis is. If it is severe, then obviously surgery has to be cancelled, and this has to be fixed first. Then the other scenario is about mitral regurgitation patient. In that case also, I think it only makes sense if the patient has had the valve replacement already and is now going for the general surgery operation, whatever it is. Then we can say the preoperative things that, for high thromboembolism risk, we can, avoid that by giving this thing, low molecular weight heparin and all these things. Because otherwise it doesn't make sense that they are giving each time new things about cardiovascular.
Dr. Asra, it is not new. As far as you will find all the 5 stems. You are following the notes in budget notes. It's there like for 1 year, so you can find it that all 5 stems are given there. The
That's
fifth
true.
stem is
That's true. I have read the 5 stems, but the thing is that
Yeah.
I have not read judgment in terms of if the patient will, let's say, have mitral regurgitation and he is going for a hernia, then what you will do. Let's say I tell you that this patient is a Mr. Fitzgerald, and he is 56 years old. He's going for hernia repair tomorrow, and he has had a recent echo done which shows mitral regurgitation. And what will you take? The preoperative precautions.
Just think from your level, Doctor. You will just inform the cardiologist. You will take, if it is an elective surgery, you will inform the cardiologist after doing this echo and ECG. If he permits, you will go for the operation. Otherwise, you will not. That is the thing.
Yes,
If it is an emergency procedure, you will also inform him. And then if they ask you what precaution you can take from your point of view, then you can say more.
Yes.
We are not allowed to make this decision.
That thing made well, exactly. Yeah, that's what I was thinking. Okay. And then why were they asking then about intraoperative? Like, for example, if we say patient is not fit to go for surgery, then how can they ask intraoperative?
For that one, that is if the patient is fit to go for operation.
To go for operation.
That we still have to be cautious. Okay. For example, prepare CPR equipment and shock equipment, defibrillator equipment available. Then available, then notify the anesthesiologist and the surgeon, knowing that the patient can develop any cardiac complication on the table. And we should be prepared for any complication that could arise. Then monitoring the patient's vitals and also INR, just
okay.
Yeah.
Okay. And also there was one, sorry, I'm asking a lot of questions. One question is that yesterday we were doing, there was somebody had written that he got a lymph node exam. Now, I don't know where he got the lymph node exam, whether it was submandibular exam or cervical exam, or what kind of a lymph node exam was it. But that will also be news, because lymph exam hasn't come, examination-wise hasn't come before. Was in 2020 papers.
Really, lymph nodes?
Yes, only lymph node. It was written that patient has a family history of bowel cancer, and patient came in with a new enlarged lymph node. So
Okay.
kindly do a lymph node
Supraclavicular region.
examination.
Which group?
Okay.
Supraclavicular. Then,
Yeah. If it
I'm
was
the one,
this. Yes.
if I'm the one, then I will examine all the lymph nodes from edge to like the to popliteal. So I will start from the from edge, all the group or edge, neck, supranochia, occipital, preauricular, posterior, anterior to cerebellum, posterior cerebellum, submental, submandibular, supraclavicular, infraclavicular, axillary, all the group in axillary, then in fossa, then go down to region, then popliteal. So because if it is lymph node, examine all the lymph node, and depending on the group, you understand, from the group, we can always, like supraclavicular now, if left side, then we can think of probably gastric cancer. So I would say I would like to complete my examination by examining abdominal examination, because I feel that could be from abdomen. Just there's no need to panic.
If you do the whole body lymph node examination, so you will just palpate all of them, and if you find a lymph node somewhere, then you will palpate and examine, inspect and palpate, do everything for that one. You can't really do it for all body lymph nodes to examine each of them, inspect, palpate, and all those steps, isn't it?
Yeah. See, if I'm asked that kind of question, I will do the whole body lymph node. I mean, all the groups, not the major groups, which, like I said, from head and neck, supraclavicular, infraclavicular, axillary, popliteal. Those are the main group of lymph nodes. After checking everything, then any group that's enlarged, then you know where it comes from. For example, left supraclavicular lymph node, you think of the abdomen or stomach, right? So if it is the occipital lymph node, you think of head, posterior part of the head or skull, cavity of the neck. You understand? If it is inguinal, you think of anything from the lower limb. So once you know the group that is enlarged, then you can always know where to focus on for the kind of pathology that could lead to it. And if everything is enlarged or multiple, you can think of lymphoma.
Yes.
Okay.
Instead of being panicking, just flow with the scenario. You record that you have discovered.
Lipoma's examination has come several times.
Which examination, ma'am?
Lipoma.
Lipoma. Superficial examination of the lump.
Okay.
All right. Yes. Any more questions? Or should we move on? Or you've got tired?
That's all from me anyway.
Yeah,
I had
that's
a
okay.
question. So thanks everyone.
Most welcome. Yes, no problem. Ask, because your exam is so soon. So whatever questions you have, we can wait. You can ask, or whatever discussion you want.
And ma'am, can you actually tell that, for example, like there are so many examinations, and so like we have done almost all, but we are following particular notes, like so particular person's notes, so mainly. So now is there anything, do you think that we should focus on more particularly, that comes more? For example, we saw a lot that backache was there in a lot of stations. It's been asked a lot in last years, like the history wise, a lot of time it has been repeated. So is there anything like that you would want us really to focus on in the last day, that you would say that it's really important and we should never miss it, or something like that? Because
yes, there is a list.
Drop
If there is a kind of list of
new
all
to
the
us.
important stuff.
Sorry,
Because
both
I
were
think
talking. Yes. Yes, what Dr. Ishfaq was saying is saying, I was also going to say the same. If you know at which center you're going to appear, so it will be better that you go through the recalls of that center and then focus more on those. Or if you can just tell me, and then I can have those stations for revision, then it will help you.
Okay. Yeah, makes sense. Well, you
So,
know, the notes, the recalls, or the past papers, they are not by examination center, I think. Some
no,
of the
there are
2020
many.
ones. Rest of them I have seen it. Yeah, rest of them are, but then
2020 mostly were in Myanmar and Egypt, and even even UK as well. So yes, they were center-wise, what I know.
okay.
So, does anybody
Okay.
have any past one from Sheffield?
Sheffield, I have old ones, but I don't think I have any new.
Okay, please send me the old one.
and ma'am, do you have ones for Ireland like RCSI board? Do you have any recalls
Yes,
for that?
recalls
You
in the
have.
group. Yes, maybe
Okay.
So is
of
it separately done?
2024.
You sent two of the files to me, 2018 and 29. Is this everything in them, or there any separate ones by center
There are
wise as
separate
well?
ones. Yes, there are separate ones.
Oh,
But I
Those
think,
are
ma'am, does it matter? Like, for example, which center, does it matter that, for example, if I'm
it
saying,
does.
okay,
It
Yeah.
does. This is what I'm trying to tell you. There are certain
no,
favorite stations for particular center which are not repeated or not frequently seen at other centers.
okay,
Okay.
okay.
Yeah.
And
I'll try to find it in the group.
yeah, I will also try to find it because I didn't see according to that. Okay.
The recalls of 2020 are in the
Ma'am,
groups, Dr.
the
Ghaffur.
2019, 2018
18 and
ones
19,
are
yes.
according to the session. Yes, it's given according to the center, ma'am.
Centers, yes,
Inside it,
that's what I'm saying.
so you
But
can
it
check
was
it.
compiled by someone and they just, thanks to them, they just dropped in the group and it's being circulated. And it's like on my side, I'm lazy. I should accumulate or collect all the 2021s and then I should also make them compiled. I should. Okay, I'll try.
Please,
In a day or
2021
in
is
a day or so,
one of the.
I'll try my best. Okay. Because once
Okay,
sometimes
ma'am.
they tell me and then sometimes once they come online then they tell me not to record and they just tell me and then my memory is not that good. I forget what they told me, but if they write to me then it's okay, it stays with me. So I'll try to gather them by tomorrow. Yes, or yeah, it's weekend, so I'll see how much I can collect and gather. Yeah. Right, should we call it the end? I've got two stations. Dr. Muhammad Al-Tahir, maybe I can do his and then we can, because poor fellow is waiting. Or if you are tired, then maybe share in the, okay, I'll again share in the group. Yes, Dr. Muhammad Al-Tahir, are you ready?
I'm sharing it, ma'am. You can focus
All
on
right,
this.
good. Thank you. Yes. Should we go ahead?
Yes.
Yes.